High cholesterol does not hurt. It does not announce itself. There is no pain, no fatigue, no warning sensation that something is building inside your arteries. You feel completely normal while, over years, plaques accumulate along vessel walls, narrowing the channel, stiffening the artery, setting the stage for a heart attack or stroke that will arrive without any prior signal that it was coming. This is what makes high cholesterol genuinely dangerous, in a way that most conditions are not. Most serious diseases produce symptoms that eventually drive people to seek care. High cholesterol produces silence, and the silence can last for decades. Except in one place on the body, one visible physical sign that cholesterol is high enough and has been high enough for long enough to deposit itself in tissue you can actually see. Look at the eyelids. Specifically, look at the inner corners of the upper eyelids, and sometimes the lower, for small, soft, yellowish deposits that sit just beneath the skin. They are slightly raised. They are not painful. They do not itch. They look, at first glance, like a small patch of discoloration, or perhaps a skin tag that has gone yellow. Most people who have them have had them for years and have assumed they are cosmetic, a skin condition, a sign of aging, something a dermatologist might address if it bothered them aesthetically. They are called Xanthelasma, and they are cholesterol. Specifically, they are deposits of lipid-laden macrophages, immune cells that have absorbed excess cholesterol from the bloodstream and accumulated under the skin. The body, unable to process the cholesterol circulating at high concentrations, deposits it in soft tissues. The eyelid is among the most common sites, because the skin there is exceptionally thin, and the underlying connective tissue is loosely organized, making it an easy place for lipid deposits to accumulate and become visible. The relationship between xanthelasma and cardiovascular risk is more significant than most people who have them realize. A Danish study published in the British Medical Journal followed over 12,000 people for more than 30 years and found that the presence of xanthelasma was associated with a 48% increased risk of heart attack, a 35% increased risk of ischemic heart disease, and a 69% increased risk of severe atherosclerosis, independent of measured cholesterol levels. That last point is critical. Even in people whose standard cholesterol blood test appeared within normal range, xanthelasma predicted cardiovascular events. The deposits on the eyelid were detecting something that the blood test was not fully capturing. This is partly because standard cholesterol testing measures total cholesterol, LDL, HDL, and triglycerides, but does not measure the duration of exposure, the particle size and density of LDL, the degree of oxidation, or the individual's metabolic response to circulating lipids. Xanthelasma represents years of lipid processing failure made visible. It is a cumulative record written in tissue, not a snapshot of today's blood level. Xanthelasma is not the only place cholesterol deposits externally. In people with severely elevated cholesterol, particularly those with familial hypercholesterolemia, a genetic condition affecting approximately 1 in 250 people that causes LDL levels dramatically above normal from birth, cholesterol deposits in tendons as well. Tendon xanthomas are firm, nodular deposits that develop most commonly in the Achilles tendon and in the tendons over the knuckles. They feel like thickening or nodularity in the tendon, rather than the tendon itself. An Achilles tendon that is visibly thicker than expected, that feels ropey or nodular under the fingers, in a person without a history of tendon injury, is a physical sign of long-standing very high LDL cholesterol. Familial hypercholesterolemia frequently goes undiagnosed for decades precisely because cholesterol has no symptoms. Tendon xanthomas, when present, are one of the few objective physical findings that suggest the diagnosis in the absence of genetic testing. Corneal arcus is a third visible manifestation, a gray or white arc that forms at the outer edge of the cornea, the clear part of the eye. In people under 45, a corneal arcus is clinically significant and associated with elevated lipids. In older adults, it is common enough to be less diagnostically specific. But in a person under 40 or 45 with a visible arc around the iris, particularly combined with xanthelasma or family history of early heart disease, it completes a picture that warrants aggressive investigation. The reason these visible signs matter is not the signs themselves. It is what they indicate about what is happening where you cannot see. Cholesterol deposits on the eyelid skin and in tendons form when circulating LDL is high enough and has been high enough for long enough to saturate normal processing pathways and begin depositing in peripheral tissues. If cholesterol is accumulating visibly in soft tissue at the surface of the body, it has been accumulating invisibly in the walls of arteries throughout the body for the same period of time. Atherosclerosis, the buildup of cholesterol-rich plaques inside arterial walls, is the process that makes high cholesterol deadly. It begins not with cholesterol simply sticking to the inside of arteries, but with a more complex sequence. LDL particles, particularly small dense LDL, penetrate the arterial wall and become oxidized. The immune system detects them as foreign and sends macrophages to engulf them. Those macrophages become foam cells, exactly the same lipid-laden immune cells that appear in xanthelasma, and accumulate within the arterial wall, forming the fatty core of an atherosclerotic plaque. The plaque grows. It becomes fibrous. It may calcify. And at some point, often triggered not by the size of the plaque but by its rupture, it blocks the artery suddenly and completely. The heart attack or stroke that results does not come from the largest, most obstructive plaque. It comes from a smaller, vulnerable plaque that ruptures. The first symptom of that rupture is the cardiac event itself. This is why the word silent is accurate in a way that understates the real problem. It is not just that high cholesterol produces no symptoms before the cardiac event. It is that the process that leads to the cardiac event actively advances without producing any functional limitation. A person with significant atherosclerosis can exercise, work, feel well, pass a routine physical examination, and have a normal resting ECG, right up until the moment a plaque ruptures and the artery closes. The only intervention point is before that moment, which requires knowing cholesterol is a problem before the event demonstrates it. A standard lipid panel gives 4 numbers: total cholesterol, LDL, HDL, and triglycerides. These are useful. They are not complete. LDL particle number and LDL particle size, measured by an apolipoprotein B test or an NMR lipoprofile, tell a more precise story. ApoB, apolipoprotein B, is a protein present on every atherogenic lipoprotein particle. Each particle carries exactly 1 ApoB molecule. Measuring ApoB is therefore a direct count of the number of potentially atherogenic particles in circulation, which is a stronger predictor of cardiovascular risk than LDL cholesterol concentration alone. A person can have an LDL that appears acceptable while carrying a high particle number of small, dense, particularly atherogenic LDL. The standard test misses this. ApoB does not. Lipoprotein A, Lpa, is a genetically determined lipoprotein that significantly elevates cardiovascular risk and is present in elevated concentrations in approximately 20% of the population. It is not included in a standard lipid panel. It does not respond to statins the way LDL does, and it can drive atherosclerosis in people whose standard cholesterol profile looks perfectly acceptable. A person with normal LDL, normal HDL, and elevated Lp(a) is at substantially higher cardiovascular risk than their lipid panel suggests, and will never know from a standard test. Coronary artery calcium scoring, a low-dose CT scan of the chest that takes minutes and requires no contrast, directly images calcified plaque in the coronary arteries. A calcium score of 0 indicates minimal atherosclerotic burden and very low short-term cardiovascular risk. A score above 100, or above the 75th percentile for age and sex, indicates significant plaque burden and changes the treatment calculation entirely. It is the closest thing available to looking directly at the arteries rather than inferring their state from blood markers.